We would like to thank all of you as attendees tonight for the invaluable role that you all play in patients' lives. Many of you cure cancer and focus on survivorship and truly impact every life that you touch, so thank you. Tonight, we are thrilled to have both Dr. Salacio and Mary Callis as our panelists. Tonight, our panelists will be discussing radiation fibrosis, which is a side effect of breast cancer treatment that is oftentimes overlooked, neglected, and insufficiently discussed. I did want to mention we'll have time at the end for questions, so please submit anything that does come up during the presentation in the Q&A box. So starting off, we are going to introduce Dr. Salacio. Dr. Salacio received his medical degree from University of Florida College of Medicine, and he did his surgical internship at Caraway and his radiation oncology internship at University of Alabama, Birmingham. He worked as a medical director and chairman at Florida Hospital Division of Rad-Onc for over 20 years, and he was also the co-medical director at the Gamma Knife Center at Florida Hospital. Since 2017, he has lived in Alaska, and he has worked as the medical director at Mat-Su Valley Cancer Center. He also subspecialized in breast cancer, where he implemented the first patient care coordinator position and multidisciplinary breast clinics and tumor boards. Dr. Salacio is often asked, why Alaska? So this next slide here, we did have some pictures that Dr. Salacio took to answer that question for you all. Our next panelist is Mary Callis. Mary is a PT with over 23 years of experience as a clinician in outpatient, acute care, home health, and private practice. She's very passionate about treating lymphedema and is a CLT through Norton. Mary holds certifications that include cancer exercise specialist and functional dry needling specialist. She is currently a senior clinical specialist at Tactile, and she does an excellent job providing ongoing clinical education and training around lymphedema. So welcome to both of our incredible panelists. Thank you so much for educating us tonight and sharing your wisdom. So what we're going to do is actually start off with a poll question. So if everyone in the audience, attendees, if you could just tell us a little bit about yourself by clicking what is your specialty? Okay, so it looks like we have a lot of CLTs, several PT or OTs that are maybe thinking about being CLTs, and then also a few doctors with us tonight. Okay, Dr. Salacio is going to start us off.
Thank you, Caitlin, and thank you to all the attendees. I appreciate it. We're going to try to cover in the next 45 or so minutes a different perspective, trying to educate and explain our perspective on the management of radiation-induced fibrosis and edema. We're first going to look at more of a historical perspective of the management of breast cancer, identify risk factors, discuss some cases and how to identify lymphedema and fibrosis, and then look at trends in radiation therapy that can reduce the risk of edema and fibrosis, but also potentially increase the risk. And then Mary will spend a lot of time going over the management options. Next slide, please. Thank you. So to get started, the primary treatment for breast cancer involves surgery. And the earliest recorded surgery for breast cancer dates back to 1600 BC. In the late 1800s, Dr. William Halsted perfected what became the standard of care, radical mastectomy. He felt the best way to cure patients was to remove all tissue en bloc. And this involved removal of the breast, removal of the pectoralis major and minor muscles and the axillary lymphatics. He was also known to develop the supraradical mastectomy, and some physicians even went on to try to dissect the upper internal mammary lymph nodes. That was known as the extended Hallstatt. This procedure created significant edema, especially in the upper extremity, paresthesis, limited mobility, but it carried with it a control rate of approximately 80% and a cure rate of approximately 40% at 5 years, which wasn't bad for that time. Next slide. So looking at the anatomy that we'll address with radiation as well as surgery, there's the mammary gland, skin, lymphatics of the dermis, of the axilla, interpectoral lymphatics, as well as internal mammary nodes, major and minor pectoralis muscles, the vasculature, and the brachial plexus. Next slide. So the main lymphatics draining the breast are the axillary lymph nodes, which are divided into 3 levels based on their location with respect to the pectoralis minor muscle. Level 1 is below, level 2 is behind, and level 3 is above. Next slide, please. This slide is not meant to be digested. It's just to give a perspective that back in the mid-60s, a physician, Dr. Gallagher, who practiced out of Harvard, was focused on the post-radical mastectomy edema and potential causes. So he looked retrospectively at approximately 200 patients, half of whom were still alive. They brought them in, they measured the circumference around the ipsilateral bicep and divided edema into 3. Non-significant was a 1 centimeter or less increase into circumference. Mild was 1 to 5 centimeters, and anything above 5 centimeters was considered significant. Of those patients who were brought in, 2/3 had edema, 15% had significant or marked edema, and he was trying to determine what was the possible cause. He identified several, including a fibroblastic response, the existence of axillary lymphatic involvement, post-op infection, phlebitis, and whether or not patients received radiation therapy. But he also identified obesity as a risk factor. Next slide, please. So in the early 70s, a surgeon named Dr. Bernard Fisher looked at ways to minimize the risk of lymphedema secondary to radical mastectomy. And so he conducted a clinical trial that looked at preserving the pectoralis muscle group. Patients were randomized to both. They also included the removal of lymph nodes, levels 1 and 1.5 from the axilla, and the cure rates were identical. So the radical mastectomy, popular from the early 1900s to the early 1970 range, was then replaced by modified radical mastectomy. Unfortunately, in the early days, they still treated the axilla as part of the therapy for breast cancer, not only removing the lymph nodes, but stripping the veins of lymphatic vessels, which dramatically increased the risk of arm edema, as illustrated in the pictures on the right, where patients underwent significant axillary dissection. Next slide, please. As we move forward into the late 70s and early 1980s, there was a movement in oncology to preserve organs. The larynx was the primary organ studied, and then it transitioned over into breast preservation. So several prospective clinical trials were conducted that randomized patients to either the standard modified radical mastectomy or lumpectomy, also known as a quadrantectomy, followed by intact breast irradiation. Both involved axillary dissection. And what those studies showed was that whether a patient had a modified radical mastectomy or radiation after a lumpectomy with no evidence of recurrence, or if they developed a recurrence, they went on to have a modified radical mastectomy, cure rates were the same. These patients received whole breast irradiation followed by a tumor bed boost. Back in the day, it was the early days of CT imaging. So the boost was defined as a 2 centimeter margin around the scar. Most patients had a geographical miss. So the early studies showed recurrence rates of 1% per year. 5 years, 5% of the patients recurred. 10 years, 10%, and so on. Later, as CT scans became developed, we developed 3D treatment planning. And that recurrence rate today is in the 1% to 3% range. Further down the road, they looked at, can we eliminate radiation therapy by just extending the quadrant of resection? And those studies showed that about 35 to 40% of the patients had a recurrence with just a wider resection only. And then another study was performed that looked at replacing radiation with chemo, same recurrence rate. So the conclusion was breast cancer is a disease of the mammary gland. It required local treatment, either removal of the breast or removal of the tumor, followed by radiation therapy. Next slide, please. One of the most remarkable changes in surgical approach to management of breast cancer happened in the early 90s when doctors Morton and Cochran identified the primary lymph node or sentinel lymph node draining the breast. A radioactive material, or it was a blue dye actually, was injected in the Department of Nuclear Medicine around the nipple areola complex. That dye was taken to the primary lymph node, and at surgery, they excised it. If the lymph node was positive on frozen section, they went on to do an axillary dissection. If not, they stopped there. Dramatically changed the side effects related to management of the axilla. It was also better understood that sampling the axilla was more of a diagnostic procedure, not a therapeutic procedure. It is the standard, the gold standard today, and dramatically reduced lymphedema associated with surgical management of breast cancer. Next slide, please. So modern surgical techniques today include preserving the nipple areola complex, and in many cases, in multidisciplinary centers, skin-sparing mastectomy with or without immediate reconstruction. Lumpectomy is still the primary treatment, typically done with an axillary lymph node sampling or eliminating that. And in most major centers, the surgeons are either breast fellowship trained or surgical oncologists. Next slide, please. So we shift from the surgical management and its associated side effects to radiation therapy. And to understand radiation therapy, understand where it started. So in 1895, William Conrad Roentgen, as you all probably remember, discovered X-rays accidentally. There was a graduate student in Chicago, Emile Grube, who was perfecting these X-ray, these cathode ray tubes. They didn't know much about it, so he would literally hold his hand outside the tube for hours every day. He was right-handed, so he was primarily looking at his left hand. Over the course of a few weeks, he developed edema, erythema, and pain in his hand. So he went to see his primary care physician, who was giving a lecture at Hoddeman. And after the lecture, the PCP was talking to some physicians, and Emile went up and asked him if he could help and explain what was going on. Well, there was another physician there, a Dr. Ludlam, who saw the results of exposure to X-rays and questioned whether or not that could be beneficial in certain patients inflicted with TB or breast cancer. So the next day, he sent a patient to Emile for possible treatment. Her name was Rose Lee. She was a 50-year-old woman who had a history of left-sided breast cancer, had surgery, developed a chest wall recurrence, had pain and bleeding. Next slide, please. Oh, there we are. So on January 29th, 1896, the first patient was treated. She had 18 one-hour sessions over the course of 2.5 weeks, supposedly had relief of pain and bleeding, and then unfortunately succumbed shortly thereafter. Next slide. So this is what can happen with extended exposure to radiation therapy. This is his hands. He lost digits, lost function. Next slide, please. So when we look back at radiation therapy, it initially started off with cesium as a radioactive material providing it. Later in the 60s and 70s, cobalt became very popular, and there's still units today. And then the treatment unit most commonly used today is known as a linear accelerator. These accelerators generate high energy X-rays or photons. The higher the energy, the deeper the delivery of the radiation therapy, and the more skin sparing. So in the early days, we didn't have CT, so it was just an X-ray, APPA, treat patients, accept a lot of collateral damage. Later, as CTs developed, we were able to design treatments in a more 3D conformal fashion, which is still commonly used today. And then about 20 years ago, Varian Medical Systems, the leading manufacturer of linear accelerators, developed software known as intensity modulated radiation therapy, or IMRT. That essentially allows us to customize any treatment, hit the target, spare surrounding tissue. We literally can treat around a structure and it's sub-millimeter accurately. Accelerated partial restoration is another technique we use, where we take the tumor bed and we can deliver treatment from within using a radioactive source or using IMRT to deliver treatment just to that area in as little as 5 days. Today, in this country, hypofractionated radiation therapy has taken the standard, which is typically 5 to 6 weeks of whole breast irradiation, followed by a 1 to 1.5 week boost to the tumor bed, down to 3 weeks of radiation therapy to the whole breast, followed by a boost. And in some cases, we can do hypofractionated treatment without a boost. Most of my practice today is focused on the more current literature, which takes that same course of treatment, 3 weeks, and in women who need a boost to the tumor bed to achieve that high local control rate of greater than 95%, we can do it simultaneously. It's known as a simultaneous integrated boost, or SIB. So we can treat the whole breast to 40 gray in 15 fractions, and within that target, deliver a higher dose. And the results are excellent. Patients tolerate it very well. Some of the more recent studies are looking at identifying patients that we can actually omit radiation therapy to. However, sometimes when you increase the dose of radiation therapy, you can induce higher rates of acute side effects. You can affect cosmetic result down the road or even increase fibrosis. Next slide. So with radiation therapy, there is a response, just like anything that affects normal tissue, and that's usually on a cellular level. The acute damage is usually more vascular, associated with localized edema, inflammation, and then more chronic or further down the road, you see narrowing and or occlusion of small vessels, which can lead to fibrosis. An old way of looking at radiation therapy damage that is still popular today is known as TD55, which represents the minimum dose to tissue where less than 5% of the patients develop a complication within 5 years. That becomes the gold standard. So we limit the dose of that tissue to that dose or less. TD55 is when 50% of the patients develop that complication. We definitely stay away from there. Next slide. So there are 3 classes. Class 1 tissue is where radiation damage causes severe morbidity or mortality. Brain, bone marrow, spinal cord are examples. Most of the tissue associated with radiation therapy for breast cancer, fortunately, falls into the class 2 range. Breast, muscle, lymph nodes, the lymphatic vessels, large arteries and veins, and then the skin and peripheral nerves are more of that class 3. Fortunately, most of the tissue we're targeting containing subclinical disease, cancer cells, tolerates a higher dose than that is necessary to achieve a high control rate. Next slide, please. So we get asked all the time as radiation oncologists, why does the radiation therapy, or how does it know to kill cancer cells and not kill normal cells? And this is an old concept that is still popular today. It's known as the therapeutic ratio or therapeutic index. And then what it is, it's a fine line. So as you probably know, cancer cells are normal cells that have lost control. Normal cells normally divide when another cell dies, in simple terms. Cancer cells is when that control mechanism is lost. So those cells divide more rapidly. Because they divide more rapidly, they're in that phase known as mitosis just prior to dividing, where the DNA is very concentrated. That's when it's most susceptible to radiation therapy. So what we try to do is deliver a tumoricidal dose that achieves high control, but still stay well below the tolerance dose of normal tissue. So what damage does occur can be repaired. It's known as sublethal damage. Next slide, please. So what are the risk factors? Comorbidities include a high BMI. The higher the BMI, the higher the risk of breast edema. Breast size, AB cup, 15% risk with radiation therapy. Anything larger approaches 50%. The surgical technique, we see that all the time, that surgeons use different technique based on their training. Something as simple as the alignment of the lumpectomy incision can affect the ability for lymphatic drainage and result in lymphedema and fibrosis. And I'll show you a slide like that in just a minute. The extent of the axillary surgery, a sentinel lymph node biopsy or no surgery, has less morbidity associated with it than an axillary dissection. The stage of cancer, if someone presents with regional lymph node involvement, several lymph nodes, they have a higher risk of lymphedema. There's going to be more scar tissue associated with radiation therapy in that setting. The technique of radiation therapy, modern day IMRT, is skin sparing. We literally start the dose of radiation approximately 5 millimeters below the skin, going to have less long-term effect than radiation therapy delivered using a 3D conformal technique where you deliver a higher dose to the skin. You just can't spare it. So, and dose per fraction, higher dose per fraction, the higher the risk. The more volume you treat, larger breast, more risk of edema. And skin sparing, if you do not utilize skin sparing technique, you're going to increase the risk of dermal lymphatic edema. And the homogeneous dose, the more conformal the dose, the less the risk of edema and fibrosis. The two patients on the right are typical for what we would see using 3D conformal technique in a large breasted patient. You can see the residual effects. This is months after our treatment, increased breast size, erythema, and you can see the effect on the nipple areola complex. On the lower patient, you can actually see hyperpigmentation just along the inferior aspect of the upper abdomen where the radiation therapy field extended using a 3D conformal approach. My technique today is I rarely include the nipple areola complex because we can carve it out and reduce a lot of that risk. Next slide, please. So this is an example of a patient I treated a few years ago. She was a young woman. Her tumor was in the 8 o'clock position, fairly deep. The surgeon removed a lot of tissue. So removal of tissue led to a fair amount of fibrosis. Then we add the radiation therapy to it, increased it further. She didn't have a lot of breast edema. She just had a lot of fibrosis. Today, if I were to see this patient, I would have her involved in a management protocol before the start of radiation to reduce that risk. It can be corrected with plastic surgery. Next slide, please. So this is an example before we get into how to manage and treat patients. This is an example of the worst that can happen. This is a delightful lady that I saw approximately 2 years ago for a benign brain tumor. I've been following her. She's never needed treatment for that, but her arm was about almost 3 times the size that you see here. When she was in her 20s, she was diagnosed with malignant melanoma involving her right breast. She underwent a radical mastectomy. So not only was the breast tissue removed, the pectoralis major and pectoralis minor muscles were removed, and all of her axillary lymphatics. She then received postoperative radiation therapy. So malignant melanoma responds to radiation therapy, but you have to give a higher dose per fraction. So she went to a clinic in Kansas City where they were conducting a clinical trial. They not only increased the dose per fraction, they increased the total dose. And the result of that radiation, part of it can be seen here. You can see her chest wall still has hyperpigmentation, has telangiectasia. You see her posterior shoulder girdle has atrophy. She had developed what's known as a brachial plexopathy, damage from the high dose radiation therapy. So when I saw her, I became more focused on her edema and her pain. So I referred her to my lymphedema team, CLT and Melissa Bradley, who works for Tactile. And within a short period of time with treatment with the device, her edema was reduced by approximately 2/3. Her pain's nearly gone. She still has no function, but when she was diagnosed back then, she was also told to make out her will because she had 6 months to live. So she's very pleased to be alive today and accepts the fact that she'll never use her arm again, but her pain and edema have dramatically improved. So I think it's time to turn over to the expert in tonight's evening presentation.
Good evening, everyone. That was great information, Dr. Salaccio. I really enjoyed seeing that. So let's talk about radiation fibrosis and why is it significant? Well, it develops as an acute or long-term disability following cancer treatment. It can affect any tissue type, and it's generally a late complication that may not manifest for years after treatment. Nearly 2/3 of all cancer patients will receive radiation therapy as either a primary curative treatment, as adjuvant therapy, or palliation of symptoms. And radiation-induced fibrosis, as we've seen, can cause both cosmetic and functional impairment, which can lead to deterioration in quality of life and really requires multidisciplinary management. So radiation fibrosis syndrome describes a multitude of clinical signs and symptoms that result in fibrotic tissue sclerosis. Acute symptoms occur during and immediately after treatment. Early delayed symptoms occur up to 3 months after completion of treatment, and late delayed symptoms occur more than 3 months after the completion of treatment. So fibrosis, regardless of the etiology, will present with symptoms similar to those seen in wound healing. And consistent with wound healing, tissues that are radiated will go through the phases of homeostasis, inflammation, proliferation, and remodeling. However, we know that scarring is the natural response of all tissue healing, but fractionated radiation can cause repetitive injury to the site, where it's directed, and that can lead to an accumulation of inflammatory responses and dysregulation of wound healing. Keep in mind, patients aren't always educated about the signs and symptoms of radiation-induced fibrosis, and unfortunately, it is not always clinically recognized in a timely manner. Next slide, please. To provide more detail regarding the pathophysiology, shortly after radiation, a cascade of events occur which damage normal tissue, injuring blood vessels, connective tissues, and cells in the affected area, which triggers an inflammatory response leading to the release of cytokines and growth factors. Fibroblasts are activated, which leads to excessive protein production of collagen and scar tissue. Oxidative stress and the generation of reactive oxygen species disrupts normal tissue repair processes and contributes further to the fibrosis. The effects on nearby structures results in endothelial cell damage in the lining of blood vessels and lymphatic vessels, which affects flow and nutrient delivery to nearby tissues. Next. Therefore, radiation fibrosis is the result of a misguided inflammatory wound healing process that becomes chronically upregulated. It is clear from both experimental and clinical studies that inflammation is critical in the pathophysiology of lymphedema and fibrosis. Immune cell sensors are triggered or upregulated following radiation therapy, alarming the system to initiate ongoing inflammatory responses. That chronic upregulation of the immune system leads to chronic inflammation, chronic fibroblast activation, excessive lipid accumulation, and altered remodeling of the tissues. Next. A number of factors increase the risk of radiation fibrosis. In addition to the dosing factors discussed by Dr. Salaccio, other factors would include concurrent use of chemotherapy, as well as incorporation of surgical management pre and post radiation therapy. Patient-related factors like pre-existing connective tissue disease may also contribute. More recently, genetics have been found to play a part in predisposition to radiation-induced fibrosis. For example, radiation-induced fibrosis has been associated with a genetic variant in the ATM, or the ataxia-telangiectasia mutated gene, which is responsible for the repair of DNA double-strand breaks. These and other DNA alterations are long-term and likely play a significant role in the development of chronic fibrotic response that persists even after the initial insult is no longer present. Next. Some of the impairments observed in breast patients with radiation fibrosis include musculoskeletal effects such as shortened muscles, pain, contracture of tissue, weakness, spasms, and fatigue. Neurological signs may include sensory loss, cervical radiculopathy, brachial plexopathy, post-surgery, post-breast surgery pain syndrome, and complex regional pain syndrome. Bone-related factors can become an issue if the patient develops osteopenia or osteoporosis with an increased fracture risk. Cardiopulmonary impairments may occur due to myocardial or pulmonary fibrosis. Integumentary concerns, of course, include dermatitis, skin adhesion to underlying tissues, and cellulitis episodes. Lymphovascular effects include lymphedema, DVTs, and axillary web syndrome. These are impairments that significantly impact quality of life and complicate restoration to former functional status. Next. So how do we approach the patient who is at risk for development of radiation fibrosis? The prospective surveillance model is recognized as an optimal framework to guide early identification and management of survivorship issues. This pathway begins with a baseline assessment of the individual's limb and upper quadrant, their physical activity level, as well as psychosocial factors. Interval screening at specific time points is performed throughout the duration of cancer treatment. The critical element of repeated interval screening ensures clinical triage pathways are developed to promote early intervention of supportive care. This model is indicated for a 24-month period, recognizing that lymphedema and fibrosis typically occur in the first year following completion of treatment. Next. Here is a tool for grading radiation fibrosis based on the induration of the tissue and how it affects activities of daily living. It measures the ability to move the skin either in a parallel or perpendicular plane, as in lifting the skin or pinching it, and it also measures how fibrosis impacts basic activities of daily living. Each description is given a grade 0 through 4, and this increases with higher grade. Keep in mind that prevention is the first step in managing radiation-induced fibrosis, and a grade 1 is still an appropriate time to start CDT to reduce the risk of increasing severity. Next. Fibrosis cannot always be recognized just with visual inspection. The Stemmer sign and bow tie test can both be helpful for identifying soft tissue thickening and fibrosis. Both tests are looking for the ability to lift the skin. However, the Stemmer sign was specifically developed to be completed at the dorsum of the hand, while the bow tie test can be completed throughout the body. Using the Stemmer sign, a clinician will pinch at the base of the second finger. A positive sign would be inability to pinch and lift the skin. It's important to note that while a positive Stemmer sign does indicate lymphedema, a negative Stemmer sign does not always rule it out, as the hand is not always involved. With the bow tie test, a section of skin is gently pinched, rolled, and twisted in one motion, and a negative test would be indicated by a bow tie of wrinkles forming, as you see on the far right. A positive test would be inability to pinch or lift the skin. If the skin is difficult to twist, or if limited wrinkles form. While these clinical signs are helpful in fibrosis detection, they should also help drive intervention and should be assessed periodically for changes and response to intervention as part of the prospective surveillance model. Next. It's important to recognize that many patients experience tissue changes in their chest, breast, and truncal areas in addition to the arm. It is estimated that 50% of patients experience truncal symptoms and approximately 30% experience breast symptoms. A patient may present with no symptoms in the arm or hand, but only in the chest, breast, or trunk. So it's helpful to ask patients specific questions about sensation of fullness, heaviness, discomfort, or pain, asking them about changes in the fit of clothing, especially the bra, or how the fit of jewelry is. There may be just a slight difference in a skin fold side to side that shows fluid retention and fibrosis. Patients may demonstrate a pot orange or orange peel textured or enlarged pores of their breast. Next. Even if a patient does not receive a pre-treatment assessment, prospective surveillance can be utilized. A very simple way to assess for symptoms associated with lymphedema and fibrosis is a symptom screener. This is a good tool to educate patients on new and changing symptoms to report to their healthcare team for prompt treatment. Patient-reported outcomes are important as studies have reported differences between patient-reported and clinician-reported skin reactions. The symptom screener is available to any clinician that may be interested by reaching out to the tactile medical product specialist in your area. Next. Various rehab interventions can be beneficial to address radiation fibrosis sequelae. Multiplanar stretching, myofascial release, postural correction, and functional retraining may be prescribed to improve range of motion, strength, promote proper breathing mechanics, and facilitate return to desired activities. Pain neuroscience concepts can be helpful for patients with nociceptive, peripheral neurogenic, or centralized pain syndromes. Weight-bearing exercises, joint protection strategies, and fall prevention programs may be indicated for patients with bone loss. Aerobic exercise and education on the RPE scale may help patients attenuate fatigue symptoms and rebuild endurance that is impaired by fibrosis. And of course, complete decongestive therapy, including manual lymph drainage, compression, exercise, and skincare, is indicated for treatment of lymphedema, skin contracture, adhesions, cording, and fibrosis. Next. In addition to CDT, you may want to consider the use of adjunct tools and modalities to treat radiation fibrosis. Low-level laser is a non-invasive form of phototherapy that utilizes wavelengths of light, most commonly 808 to 905 nanometers in the oncology population, with positive outcomes reported in 1.5 to 2.4 joules per centimeter squared energy densities. This treatment has been shown to reduce inflammation, promote lymph vessel regeneration, improve lymphatic motility, and soften tissue fibrosis. The scar tissue causes stiffness around the lymphatic vessels, which reduces lymphangion motility. Using the laser can get the deeper scar tissue to soften, thereby improving lymphatic pumping. It is best used in targeted areas of fibrosis. Deep oscillation therapy, such as the HivaMat or HivaDot, utilizes an electrostatic field between the clinician's hands and the tissue of the patient. It is an electromechanical therapy in which electrostatic attraction and friction produced using a glove or a handheld applicator create resonance vibrations in the treated tissue. Higher frequency oscillations are recommended for pain modulation and mobilizing lymphatic waste. Lower frequency oscillations produce a pulsating pumping action in the deeper tissues up to 12 centimeters to promote lymphatic drainage. And I can speak from experience that this is a very well-tolerated treatment modality and very effective with both breast cancer patients and head and neck patients. Dry needling is used for a variety of pain and musculoskeletal problems, including trigger points and fascial restrictions in the tissues. Dry needling may produce both local and central nervous system responses to restore homeostasis at the site of the trigger point and decrease both peripheral and central sensitization to pain. It is a treatment that is commonly used for muscle tightness and pain in other parts of the body with good outcomes. Electrical stimulation can be combined with dry needling to promote relaxation or reduce tension in the muscles. Negative pressure cupping devices have been shown to result in improved LDEX scores in women with unilateral upper extremity lymphedema that was greater than 1 year duration. Negative pressure devices are a good choice for a patient who is hypersensitive and less tolerant to positive pressure approaches. Elastic taping may be used to soften fibrosis and increase range of motion. It is recommended to use a paper off tension to no more than 25% tension in the taping treatment zone and no tension on the anchors of the taping application to avoid injury to the skin. It is essential to determine if there is sufficient skin integrity before applying vibration in acute and early delayed fibrosis conditions. Vibration may be used for older, indurated fibrotic tissue that is chronic in nature. Vibration can be helpful in reducing painful spasms following radiation, such as in the upper trapezius or levator scapulae muscles. And keep in mind, all of these modalities can also help in that regard. And this is ultimately where we are directing lymphatic drainage toward the supraclavicular and cervical lymph nodes. Next slide. Additionally, national guidelines recommend the use of pneumatic compression in the treatment of lymphedema, which includes fibrosis. The National Comprehensive Cancer Network continually updates guidelines for approaches to treatment based on evidence and consensus of the authors. You can see in the recommendations for early detection and referral, the NCCN recognizes patient knowledge, physical activity, compression garments, MLD, and pneumatic compression as crucial pieces to survivorship. Use of pneumatic compression is appropriate in both phase 1 and phase 2 of complete decongestive therapy as an effective home management approach. Next slide. The FlexiTouch Plus Comfort Ease provides pneumatic compression through a dynamic stretch and release to the skin, similar to manual lymph drainage. Treatment starts proximally with decongestion before draining the affected area. So in the case of our upper body garments, treatment will begin in the trunk, chest, breast areas to decongest. Our newly designed garments provide more comprehensive coverage, especially in the axillary region and the trunk. Not only will the ipsilateral upper quadrant be decongested, but the contralateral chest and trunk will receive treatment as well. We've added a strap at the axillary areas to better contour this area and assist with stimulation and drainage. Next slide. This is a patient who was initially referred after diagnosis of stage 3 breast cancer in 2011. She underwent a left mastectomy and removal of lymph nodes, 15 of which were positive. This was followed by chemotherapy and radiation therapy for 33 sessions, followed by burst radiation on the incision scar. She developed wounds with moist desquamation, followed by scar adhesion, axillary cording, and she was ultimately referred for complete decongestive therapy. She was treated with kinesiotape, manual lymph drainage, low-level laser, but she did not receive referral for pneumatic compression at that time. Current photos, the next photo is taken in 2024. The initial photo was pre-radiation. The second photo is post-radiation. And we can see significant induration, telangiectasia, axillary cording. She now has left upper extremity lymphedema. She's now in the process of obtaining the FlexiTouch. And although this patient would have benefited from earlier introduction of the FlexiTouch to her care, she can still benefit from daily use of pneumatic compression to promote her goals of participation in swimming, Pilates, and golf. Next slide. This patient's original cancer was in 2009. She underwent left mastectomy for stage 2B cancer with 12 lymph nodes removed. She received chemotherapy, tamoxifen, and Arimidex, and completed 39 radiation treatments. She was never referred to therapy for complete decongestive therapy. In 2021, her cancer recurred in the spine, and she underwent vertebral fusion at multiple levels, as you can see, followed by 10 radiation treatments. She presented to physical therapy with primary complaint of neck stiffness and 10 out of 10 pain. Palpation revealed grade 3 tissue fibrosis and impaired cervical range of motion. She was prescribed a FlexiTouch with the head and neck garments, as well as the upper extremity garment, to soften her axillary tissue contraction and deep cording, but also to the head and neck garments to treat this fibrosis, pain, and lack of mobility in her cervical spine. She was able to regain full range of motion in the left shoulder and cervical range of motion required to drive her car safely. Although she is not a head and neck cancer patient, her clinical presentation and symptom report indicated that the head and neck garments would provide relief. Although both these cases involve late intervention of pneumatic compression, earlier recognition of radiation fibrosis signs and symptoms with a referral for a FlexiTouch would have promoted both patients' quality of life and improved function and should be considered as best practice in cases involving radiation fibrosis. And with that, I think we're ready for questions.
Thank you so much, Mary. So we are going to have Mary and Dr. Salasio come back on. So the first question that I am seeing quite a bit of is, will we get a copy of the slides? Yes, we will definitely send those out to each of you after the presentation. So this first question is for Dr. Salasio. In regards to breast size, is this due to the density of the field, more lymphatic involvement?
I'm not sure I fully understand that the breast size, the increased risk of edema of breast size has to do with the amount, basically the density of the tissue.
Okay.
And when you think about it, you know, gravity plays a huge role. So most of the edema starts to occur in the dependent portion of the breast and often inferior to the lumpectomy incision.
Okay, thank you. This one, Dr. Salasio, is for you as well. I find that referring providers in our oncology department do a very poor job of educating patients of the potential long-term sequelae of radiation. Why do you think it is that the patient education is kind of lacking in transparency? And I also find that the radiation oncologists will dismiss the chronicity of radiation fibrosis. Do you have any thoughts on this?
Yeah, good question. I think part of it has to do with training. It's where you train. It's how your mentors teach you. And I was very fortunate, you know, where I trained at UAB in radiation oncology. The chairman of my department taught me to treat the patient, not the cancer only. And so you have to think through what are going to be the side effects of my treatment. And she would show me when things happen and patients they were cured of their cancer, but they had to live with that. But I think there's also, you have to have a desire to learn as you begin to practice, and really like technology and that multidisciplinary approach. So lack of transparency, they might be busy, but they probably just don't have access to the tools or know how to get there, like I'm fortunate to have.
I would say too, if there's a tactile medical representative in your area, a lot of times we can partner with lymphedema therapists to go in and do some education, or someone like Mary could come in, you know, and talk about her experience. And sometimes that's the only way that they are hearing about the latest treatment, especially within fibrosis. So Mary,
Yeah,
sorry, go ahead.
no, I was going to say I would agree with that. And, you know, until my specialist, Melissa Bradley, showed up, and I've always had this policy, you know, because I was the director for a large department. If someone wanted to present something to me, I just made it a departmental policy to let them come in and talk to my staff. And when Melissa approached us, I had no idea that this device existed. So I let her try it on me and one of my employees. And the results were so dramatic that I knew instantaneously that I could provide benefit for my patients by giving them access to this device, working with our CLTs in the community. And they do a great job working together as a team, not competing.
Thank you. Mary, what fibrosis stage, based on the stage shown in presentation, would you consider rerouting lymphatics with MLD to alternate pathways versus moving lymphatic load through a radiated area?
That's a good question. Probably I would hopefully start as early as possible when it is grade 1, so that there's still some possibility of moving. Once that skin becomes very indurated and adhesed, you really have to work at softening and increasing the mobility of the tissue before you can hope to move any lymph across a watershed.
Okay. This is a question we get pretty often, Mary. Is there high risk of triggering lymphedema with dry needling in an area that is at risk already for edema?
The research on that says no. There are studies where they have been needling women with lymphedema in their limbs and putting needles in them with no adverse effect. In fact, sometimes when you apply e-stim to it, you can actually create a pumping sensation and reduce lymphedema. So I've used it clinically for 12 years with no incidence of increased lymphedema.
Okay, thank you. Dr. Salasio, this one's for you. How do you advise patients who have had deep flap and find they need radiation? As a patient advocate, I hear a lot of questions, concerns about this. What should they be looking for in a radiation oncologist, and what questions should they be asking the radiologist to minimize the effects on the flap?
Yeah, I think that's another excellent question. I think experience, you know, a good radiation oncologist is part of a multidisciplinary team working with breast surgeons, working with plastic surgeons, and understanding the effects of radiation, but also following patients very closely and providing access. I do something probably a lot of physicians don't do. I give every patient my cell phone number. So if they ever have a question, no matter what day or time, I don't always answer it at night, but it provides access. And I think that's the big thing, is helping them feel comfortable accessing you or your team with questions. But anything that feels abnormal, you got to ask. The other thing I also emphasize, and I think if they're surgeons in the audience, they'll understand, in the early days after axillary dissection, patients were told not to work out, not to exercise with that arm. It never made sense to me, right? The exercise
Right.
increase blood flow. And fortunately, within the past 10 years, there've been some studies to show it's just the opposite.
This is
Actually, go ahead.
Just a follow-up question. I heard from different people that radiation therapy can stay in the tissue for a long time, like 8 years, 28 years. Which one is true, and what effects on patients' tissues?
Yeah, a good question. It depends on the tissue. The correct answer is, it, for the most part, will never forget, but the effective dose over time declines. So if we're treating something like the spinal cord, we try not to dismiss the prior dose of radiation, but 5 years out, there are some formulas that we have access to where we can calculate what the effective dose after the regeneration of some tissue. When we're looking at breast tissue, if you look at a patient who's had radiation therapy, if you follow them out after 6 months to a year, if they've received more modern day techniques, sometimes it's hard outside of the scar to know which breast was treated because of the turnover of the epidermis.
Mm-hmm.
I think you make a good point too, because a lot of the patients that and the two cases I presented, they had breast cancer in 2009 and 2010. They had very different techniques used then, and then they had recurrence. So sometimes it takes a lot of problem solving, trial to figure out what will work with those patients.
Yeah, I agree.
Mary, these questions kind of all go together, but I'm going to separate them. Is it ever too late to treat fibrosis? At what time can you no longer make an impact?
I think you can always make an impact.
Okay.
I think that even providing exercise in some way can promote sense of well-being, improved endurance, better outlook on life, those psychosocial changes. And often we can, I have prescribed the pump, the FlexiTouch late, with good results.
That's awesome.
I have a quick question for Mary.
Yeah.
Is it ever too early?
That's a good question. And I always work with my radiation oncologist on that, because those tissues can be very fragile. And especially in the case of using modalities, I want good tissue integrity. I don't want to cause further injury. I don't want to cause pain. I want it to be a comfortable treatment that brings a positive change for the patient and helps them achieve their goals. So that is a case by case, very unique to the patient and their situation.
Mm-hmm. That's a great question. Mary, did you treat through radiation, avoiding the radiation field, or did you wait until the patient was completely done with the radiation treatment?
I've worked around it.
Okay.
And usually waited. It really depended on what I saw. But typically, once they're done with radiation, some people wait a full 6 weeks till after, but I really believe you can start earlier than that to prevent a lot of those fibrotic changes to help limit that cascade of events that we talked about, and maintain good range of motion throughout, keep the patient moving. And exercising and not sitting in a chair or laying in bed all day, and just remaining participatory in life.
Mhm. Dr. Salacio, what was your aha moment for recognizing the importance of early identification of lymphedema?
Yeah, I think there is obviously you deal with patients who have significant side effects down the road and you wish you'd gotten involved sooner. But I had I've had some recent patients when I see them up front, usually post-op, but before radiation therapy, that have had edema, and sending them and seeing how quickly they respond. The other component of that is I've had some patients with significant side effects that I've referred for FlexiTouch because they've tried everything else. And to have a patient in a room with pain and decreased mobility undergo one session and come out and have them describe, my pain has improved. You can see their flexibility, their mobility in that extremity or head and neck area improve, and their swelling go down. And then I see patients all the time in follow-up that tell me they're religious about using their device. And so you feel like you're making a difference because you're part of the problem, right? Your treatment helped them, but in some way it's hurt them. So making them whole again. But
This is a question that we get quite a bit. So either of you or both of you could answer, what lymphedema or scar tissue mobilization therapy should be avoided during the course of radiation treatment? And are there any contraindications with the FlexiTouch?
I mean, I can go first with radiation. I I believe patients should remain active. So as soon as they have clearance from their surgeon to proceed with normal activities, I teach them exercises. Some, if they've had an axillary dissection, I teach them how to walk their fingers up a wall so they can minimize the risk of fibrosis, and to continue that during the radiation therapy.
Mary, anything to add there?
What was the first part of that question?
Of course, I've scrolled down now through the 50s.
I think it was there anything to avoid during the treatment?
Oh, a lot of times therapists ask me about instrument-assisted tools for myofascial release, and I have used those in more extreme older cases of fibrotic tissue, but early on, I have used them with very gentle touch, really to relax the nervous system, promote muscle relaxation, calming of the nervous system so that we can move on to exercise. So, but I would not recommend very deep tissue massage with instruments.
Okay. Let's go ahead and do one more question, and then there were close to 60 questions, so we can definitely get back to you if your question was not answered. But this last one is for Dr. Salacio. What is your process for assessing for lymphedema in your patients, given how busy your practice is, and what recommendation would you have for me as a clinician if I wanted to implement a protocol?
Yeah, that's an excellent question. The form that Mary showed is actually one that I'm going to adopt in my practice. But what I try to do is assess patients without adding a lot of extra time. So when I'm working up patients, I'm examining them either during consultation or in follow-up prior to radiation therapy. As I'm talking to them, I just use my thumb and middle finger around their wrist. And I had a recent 42-year-old female. She'd only had surgery. I anticipated she would need adjuvant chemotherapy, and she's receiving that. And I was actually surprised because it was her non-dominant hand, but ipsilateral side, that she had edema. So what I try to do is assess patients prior to radiation therapy and get them involved with the team, the lymphedema specialist, prior to developing worsening symptoms. So being more prophylactic. And then my role is relatively simple. I examine the patient, I document it like I have always done for all of my patients, whether it's related to breast cancer or bipedal edema. And then when I'm doing my consult note, I enter my own ICD code. So I enter the code for lymphedema, and then I've created very quick, short templates for CLT and tactile referrals that all I do is go in, open up in the patient's chart, and I fax it over. And then my staff just schedules an appointment for them. And so it really doesn't take a lot of my time. It's something I'm doing anyway when I assess my patients. And you can tell which patients are at risk once you've treated.
I agree with that. Even in my physical therapy practice, I would evaluate on day one. And you can tell by reading the history of the patient and just talking to them, assessing them, that they might benefit from a pump. So typically my second or third visit was a pump demo, just to introduce the patient, to provide them with information about resources, about what tools can help them. There was no obligation at that point in time, but I feel remiss if I don't introduce that information early on, because there's nothing worse than seeing a patient 10, 12 years later, as in the patient cases I showed, that could have benefited from early pump intervention to avoid a lot of the dysfunction that we see.
Absolutely. Well, thank you guys both for your time. Nick is going to pull up both of the speakers' contact info. So like I said, we'll definitely try to get to your question if it was not answered tonight, but they have both graciously shared their emails. So if you want to take a screenshot of that. And then the only other things that I wanted to mention, we will send a survey directly after this asking for feedback. And then as soon as the recording of this live webinar is ready, it will be on our website at tactilemedical.com. And you can also find any other previously recorded educational webinars there on several topics, including oncology and vascular. So thank you all so much. Enjoy the rest of your evening, and we will be in touch. Thank you.